Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. Today, the public health value of wastewater. Dr. Dylan George is the director of the new Center for Forecasting and Outbreak Analytics at the U.S. Centers for Disease Control and Prevention. He speaks to Dr. Josh Sharfstein about how the center is using wastewater surveillance to improve predictions of infectious disease. Let's listen.
Dr. Dylan George, thank you for coming back to Public Health on Call. Today we're going to be talking about the latest from the Center for Forecasting and Outbreak Analytics at CDC. How are you today?
I'm doing really great. Thanks for having me again.
So just to remind everyone here about what this center is about.
Yeah, the Center for Forecasting and Outbreak Analytics is one of the newest centers at CDC, and our objective is to try to use advanced analytics to empower people to keep themselves, their families, and their communities safe during public health emergencies by using data more effectively and extracting as much information as we can from the data that we have. And so in short, we're trying to create a national weather service for infectious diseases. So how can we use that same sort of functionality for infectious disease capabilities?
And you're building the toolkit now.
Exactly. We're building the team, the tools, the partnerships to actually make that all happen.
So give me an example of a project you worked on recently before we get into what we're going to talk about today. Just kind of how is this center serving the country already?
Yeah, so we've been trying to help in a handful of ways. Now, over the last respiratory disease season, we were developing different capabilities for us to understand what was happening with COVID, with RSV, and with influenza, because those are the three big pathogens that are putting people into hospitals and creating hospital strain and challenges for people with those pathogens. We were able to develop what we referred to as the disease respiratory outlook for the season that helped people understand what was the level of hospitalization that most jurisdictions could anticipate over the respiratory season from those three pathogens. Now, how that was useful was first, we were prospectively trying to anticipate that hospital burden, and the various state health officials could then go turn and talk to their hospital advisors and administrators and say, are you ready for that level of hospital burden? If so, great. If not, let's dust off our preparedness plans and make sure we are ready. And what do we need to do to get ready? And so that was an example of how we were trying to use different sorts of modeling informed thinking or modeling capabilities to anticipate what was going to be happening in the future and to make sure that we were prepared for that.
Got it. I can see how that forecast could be helpful. Of course, it begs the question, how did the weather report do? How accurate were your forecasts? And understanding that, not even the weather service hits 100% of the time.
Exactly. I mean, it was with those types of things. I mean, like with weather, it's a probabilistic statement about what's going to happen in the future. And sometimes that probability doesn't bear out. Now, fortunately, in this particular case, we were right on. I'm not right on target, but we were in the right ballpark in terms of how much hospitalization was going to be happening. And so that is a really good indicator that one, the methods that we were using are being borne out, and two, that there was some utility from having that anticipation. Now, another example of that on a shorter time scale is we've only been in existence for the last 2 years. This last year, we started developing internally within CDC forecasts for what's happening with COVID and influenza. Now, we've been supporting, CDC proper has been supporting forecasting and influenza for the past almost 10 years. But it's been academics and private sector that have been doing that work and submitting it to CDC. Now we've passed a major milestone in that we in CDC have the team and the tools to actually forecast and generate those forecasts going forward. And so we can make probabilistic statements very similar to what the Weather Service can about weather in a particular area, about what's going to happen with COVID and influenza over the next 4 to 6 weeks going forward. That is actually a very useful tool and a major milestone that we just crossed as well.
Well, congratulations on that for sure. I imagine, and you can tell me if I have this wrong, that there's data going in to your analytics, and then there's sort of predictions or forecasts coming out. And I want to ask you about the data going in. What kind of data comes in?
Yeah, we know that better forecasts start with better data. We need better data to improve this. And so the data modernization initiative and the public health data strategy that is being driven within CDC to move things forward, critically important in moving that forward. Now, there's the traditional data sources, the numbers of cases, the deaths, and the hospitalizations that are coming from healthcare and other public health data systems to help us anticipate what things are going forward. And then there's non-traditional data sources, things like digital health, wearable devices, and wastewater data. Those are all sorts of what I would kind of consider a little bit non-traditional or new data sources to help us think that through. And so those are some of the kind of novel things, particularly wastewater and wearables are generating really interesting data that might be helpful as well.
Well, let's talk about wastewater a little bit more. When we talk about wastewater surveillance, that seems like a very abstract concept. What is that in reality?
Yeah, I mean, traditionally, it's like when the way we get a lot of data from in public health is someone has to realize they're sick. They go to a clinician, the clinician orders a test, the test goes to the lab report comes back. Then if it's a reportable disease, it goes to the public health at a local level and then up to the state level and then to CDC. So there's a long lag time or long latency associated with some of those things. The thing that's interesting about monitoring diseases in wastewater is that we all use the facilities. We all, it's a biological imperative.
And just to be clear, Dr. George, when you say the facilities, I don't want any euphemisms here. Which facilities are we talking about?
We use the toilet. We all use the toilet.
All right,
yes.
Good. All right,
we use the toilet and we do our business in the toilet. And because if we also shed virus and we shed pathogens, if we are sick through wastewater, through the toilet. And so it's so we can actually, if we extract the wastewater down the line at the wastewater facility, we can actually test for different pathogens that are excreted through urine, through feces, and through other sorts of excreted materials from humans that go into the toilet. So one of the things that's really exciting about wastewater data is that it has fewer sort of privacy issues because, once you put things into the toilet, you don't really have an expectation of privacy. And we're not really tracking individuals. We're trying to think about how much disease is being spread in a community in a sewer shed. And then also there's less latency. It's a faster data source because you don't have to go to the doctor. You don't have to send the sample to the lab. You don't have to wait for it to be reported up the chain. It's a much faster data source going forward. And so there's a lot of promise associated with wastewater disease monitoring because of that. And we've made significant advances. The National Wastewater Surveillance system that Amy Kirby and Peg Honan have been developing within CDC has been made major steps forward in helping us spread these capabilities to monitor diseases in wastewater across the United States through COVID. And it has helped us understand what's going on with COVID and a handful of other diseases that are spreading and that are shed in urine and feces and other bodily fluids. Yeah.
So you've got the data from hospitals, how many people are in the emergency department, how many people are admitted. You might have data from how many prescriptions are given for a particular condition. But now you're also monitoring whether that virus is showing up in wastewater, maybe for an entire city or part of a city. How do those things line up? Like, in other words, what do you start to see first? What comes later? What's the advantage of looking in the wastewater for disease?
Yeah, you're exactly right. It's like if we can we have multiple data sources, and if we can bring those multiple data sources together in kind of like a multi-data and multi-signal fusion approach. That's a very fancy way of saying it's like, how do we bring multiple different data sources together into a model to actually make projections going forward? We can get a stronger signal as to going forward. So it's like you're going to see things happen in wastewater faster than you're going to see things happen in clinical reports from laboratories. And you're going to see things happen much faster in wastewater than you would see things happen in hospitals. And so it's a faster signal. And if we can bring all that data together in one way, in one modeling approach, that will help us extract as much information as we possibly can from all those data sources.
How big is the network for wastewater surveillance now? Like, I'm kind of curious whether my wastewater happens to be part of this. What percentage of the states are covered? What percentage of the population? Like, how big are we talking?
That's a good question. I'm going to have to defer on the specifics, but I do know that over 40 states are involved in the wastewater, and it might be more than that. And so there's a lot of involvement and coverage of wastewater data. Now, it's not the answer to everything, though, too, because, for example, 70% of the population of Alaska is on septic systems. So you're not going to get a full signal from waste. And there's lots of frontier states and areas and rural areas of the country that are going to be similarly on septic systems. And so we're not going to be getting good signal from those places. And so we need to be cognizant of some of the limitations of wastewater, but it will be helpful in some places. We need to maximize the benefit from the places that we are extracting that.
Let me ask you a somewhat technical question. When I first was paying attention to this type of surveillance, I could understand right away the ability to measure for the presence of a virus. Like, you find the virus, it's there, versus the quantity of the virus. And that is complicated because all kinds of stuff gets in the wastewater. The concentration changes. How confident are you when you're looking at some of these respiratory viruses, for example, that you can really get an assessment of the level of the virus compared to the fact that it's there?
Yeah, it's a great question. Now, I'll be the first one to admit that we need to have more standardization on the methods in which we extract pathogens or viral particles from wastewater and what types of parts of the wastewater that we're actually extracting. So there needs to be some standardization so we can compare across other areas. So lots of work is going on, and how do we actually do the operational components of extracting virus and then testing it to make sure that we've got those and that we've got the right diagnostic tests to do those going forward. And then also, it's going to be a little bit of we're going to have to be nimble about how we address that question, though, too. For example, with COVID, there was the variant called JN1 that came around. There's some good evidence that have just come out recently that are showing that we, on an individual level, we saw spikes in wastewater from JN1. And so how do you interpret those spikes as they increase? What did that mean? More people in the community were infected? Or on a per person basis or a per infected individual basis, was there more virus being shed? And actually, it was the latter. More virus was being shed per person than we had seen in previous variants. And so we need to do a little bit more exploration on how we understand these data as well. So we need to come up with standardization on methodologies and improve so that we can do cross-site comparisons in a much more efficient way. And then we also have to be nimble about what does it mean when we see changes in the levels of a pathogen in a particular place.
So would it be fair to say we are in the early days of wastewater surveillance as a tool? How have you been able to use that? Has it been helpful to the center so far, or is it still so much in development that you're waiting for it to mature?
Yeah, no, it is definitely, we are in the early stages, but it has been very helpful. Like I said, our colleagues Amy Kirby and Peg Honan and that run the National Wastewater Surveillance System have been exceptionally great colleagues, and they've been trying to find ways of actually extracting more information out of the system that they have. Some of our folks, Caitlin Johnson and our team has been one of the lead people that has been working on this. She wanted to see if we could actually include wastewater data into some of our COVID forecasts. And so she developed a capability so we could bring that information in. And we tested it out late last year to see if we could improve our forecast. Lo and behold, it actually helps us improve the forecast in a lot of ways. Again, because it's faster data, we can actually improve the accuracy and precision of the forecast, especially in terms of inflection, when you get an uptick or when you're at the peak and you get a downtick of what's happening in the hospitalizations. And it has been really wonderful to see how much it improved what was going on. So not only did we improve our forecast, our hospitalization forecast, but also we were able to link the data, the wastewater data, to what is going to be happening in hospitals in a much more effective way going forward. Because remember, wastewater data helps you understand what's circulating in the community. It doesn't really tell you what's going to happen in the hospitals directly, but our modeling linked the two together in a much more explicit way. And therefore, we provided more value out of the wastewater data than we had before. So it was very exciting to see all that happen.
And now that particular respiratory season is coming to an end, do you go back and look to see whether you could improve your models based on, what you did, whether there's a different way of counting the wastewater surveillance versus this other kind of data? And, next year you have an updated model that hopefully will be more accurate?
Yeah, completely. I mean, taking one step back though, too, is that not only did we actually test it out to see if it could be useful, we deployed it. So that all the places across the United States, the 40 jurisdictions across the United States that have wastewater data, we deployed those forecasts so that they could see that. And we did this in February. So not only did we improve our methodologies, we made it available so that people could actually use it and look at it and make it decisions on it. So because CFA existed, we developed a new methodology and we operationally deployed it in a record short time. Right. We're talking weeks, which was, wouldn't have happened without CFA being in existence. So number one. Number two, it's like looking back at the season and trying to figure out how to do things better as well. It's like we're definitely in a situation right now where we're trying to find other data sources that could help us improve our modeling going forward. We're looking very extensively at emergency department visits and what people come into the emergency department for. And does that help us anticipate what's going to happen in the with hospitalizations generally? And so we're very rigorously evaluating different data sources like that to kind of move things forward as well.
Internet searches, is that part of what you're looking at? Sometimes people say, I'm starting to cough or something, or need cough medicine. Does that factor into your models?
It absolutely does. And so there's, back in a handful of years ago, there was some really interesting sort of research that was done at google.org about how to use internet searches for anticipating what's going on in the community in terms of influenza cases and that sort of thing. And they made some really substantive advances. And there's some challenges associated with using those data because they're not, it's very non-traditional data going forward. One of the things that we've invested in 13 different awardees to help us develop new methods, look at new data sources, and then test those out with health departments. This is what we refer to as InsightNet. And we'd talked about this before. But one of our colleagues at Northeastern University is a part of that network. They are actually looking at internet searches, but then also they're working with some of their colleagues on data systems that clinicians are using for the searches that clinicians put into their systems to understand what's going on and to see if that could be useful for as an early indicator going forward as well. And I'm really excited to see how that research is going to go forward. Still in the early stages, but it's along the same lines as using internet searches in that same way that you're describing.
And you mentioned wearables. I take it that's probably also kind of aggregated, de-identified data from things people wear on their wrist, or how does that work?
There's a range of different wearable devices that we now have access to, and then they're approaching medical grade quality. And and being able to access some of those data, we're keenly interested in trying to understand what type of data in that space is really going to be useful, how it can be useful, for what purposes, and the quality assurances. And so we're looking for opportunities to explore those data sources and to assess whether or not they're useful or not. As a cautionary tale in that space though, too, it's like, as you know, very well know, it's like our healthcare system is very fragmented from a standpoint of our electronic health records and that sort of thing. For example, my son, he got a vaccine for COVID from 2 different pharmacies. And so trying to aggregate those 2 electronic health records remains a challenge because we don't have universal identifiers. As we move forward with these wearables and these different sorts of devices, it's going to still remain a challenge to have that interoperable and sharing ability amongst those different things. And so while I'm super excited about exploring these data, it's also, I'm cognizant of the challenge for data sharing and interoperability across these different platforms.
Got it. Well, that's really important work. Maybe not as glamorous as wastewater surveillance.
Well, who doesn't wake up getting excited about working on wastewater,
It just occurs to me that, this is a lot of data, a lot of analysis, all for the purpose really of protecting us. In other words, most people may not know that this kind of work is happening at the Center for Forecasting and Outbreak Analytics, but if they need a hospital bed, there will be a hospital bed for them.
Yeah, exactly. A close friend of mine during COVID ended up with a C. diff infection, a C. difficile infection, and had to wait several days to get a bed because they were being occupied by COVID. And one of the things that we hope that we're going to be working for is to be able to actually optimize the healthcare system such that they can be ready for outbreaks, and that we can actually, me, my family, and my community can be ready and know how to use that information to keep ourselves safe going forward. And so that's what we're hoping, is that this new capability will be helpful to Americans to keep them safe during public health emergencies.
People talk about public health these days as an invisible shield, so you're strengthening that shield.
Indeed. And just as a plug for your PBS series, it was a wonderful viewing, and I encourage anyone to watch that series on PBS. You had some great quotes in there. I loved it.
Oh, well, I wasn't fishing for that, but I appreciate it nonetheless, Dr. George, and great to have you again on Public Health on Call.
Indeed. Thank you.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Ceciri. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Ceciri and Eliza Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.